3 people are already dead. The ship is still at sea. And a virus that science said could not jump from person to person just did. 150 passengers, nowhere to dock. A government that slammed the port shut. And a deadly pathogen that rewrote the rules while health officials were still catching up. This is not a movie. This is happening right now off the coast of West Africa. And the question that no one is answering is this: who else got off that ship before anyone knew to stop them? Welcome. You are watching The Jang Report, and this story broke in the last 24 hours. A luxury expedition cruise ship called the MV Hondius departed Argentina in early April for a transatlantic voyage across some of the world's most remote ocean territory. It was supposed to be the adventure of a lifetime. Instead, it has become one of the most alarming public health events of 2026. 3 passengers are dead. At least 8 are infected. The World Health Organization has confirmed the virus on board is the Andes strain of Hantavirus, the only known strain of this disease capable of spreading directly from human to human. Passengers remain confined to their cabins. A country just refused to let the ship dock, and at least 1 infected passenger had already returned home to Switzerland before the alarm was raised. By the end of this video, you will understand 3 things. First, exactly how this outbreak started and why the Andes strain changes everything scientists thought they knew about this virus. Second, why the global response has been slow, fragmented, and potentially dangerous. And third, whether this event could represent the early chapter of something far larger, or whether it ends here, contained on one ship off the West African coast. We cover stories like this before anyone else. Subscribe now and hit the bell, because when this story moves, it moves fast. Let us get into it. The MV Hondius is an ice-class expedition vessel operated by Oceanwide Expeditions, a Dutch company known for taking passengers to the world's most extreme destinations: Antarctica, the Falkland Islands, remote archipelagos of the South Atlantic. The ship departed Ushuaia, Argentina on April 1st, 2026. Its route was ambitious, crossing the South Atlantic, stopping at isolated island chains before heading north toward the Canary Islands and eventually Europe. It was carrying approximately 150 people when the outbreak began. The first death occurred on April 11th. A Dutch man fell ill with a rapidly progressing respiratory illness and died on board. His body remained on the ship for 2 weeks because there was no immediate port with facilities to receive it. By late April, more passengers were showing symptoms. The illness moved fast: respiratory distress, fever, hypoxia, the kind of deterioration that in a hospital setting triggers immediate ICU admission. On a ship in the middle of the ocean, options are catastrophically limited. Oceanwide Expeditions confirmed that several passengers had contracted what appeared to be a severe respiratory illness. But it was not until the World Health Organization issued its disease outbreak news bulletin on May 4th, identifying the specific pathogen, that the full gravity of the situation became public. 7 cases had been identified, 2 confirmed by laboratory testing, 5 suspected, 3 dead, 1 British national in intensive care in South Africa, medevaced off the ship and hospitalized. 2 more symptomatic passengers still on board awaiting evacuation. The WHO declared its assessment: this was Hantavirus, and not just any strain. To understand why this outbreak is different, you need to understand what Hantavirus actually is, and why the specific strain on this ship matters enormously. Hantaviruses are a family of RNA viruses carried by rodents. Different rodent species host different strains, and those strains cause different disease profiles in humans. Most hantavirus infections occur when a person inhales aerosols from the urine, feces, or saliva of infected rodents, disturbing a nest, cleaning an old barn, camping in an area with high rodent populations. In the United States, the primary strain is Sin Nombre virus, first identified during the 1993 outbreak in the Four Corners region of the American Southwest. That outbreak killed more than half the people it infected. The mortality rate of hantavirus pulmonary syndrome, the respiratory form of the disease, runs between 30 and 40% in some documented clusters. Here is what science established about hantavirus transmission over the following 3 decades. It does not spread between humans. You do not catch it from a sick person the way you catch influenza. You do not pick it up on a surface. The only known route was rodent to human. That is, until the Andes strain. The Andes strain is found primarily in Argentina and Chile, specifically in Patagonia. It was identified in the 1990s following clusters of severe respiratory illness in remote Andean communities. Epidemiological investigations found something that alarmed researchers. Some patients had no known rodent contact, but were close household contacts of confirmed hantavirus cases. Healthcare workers in one documented outbreak also showed infection rates inconsistent with accidental environmental exposure. By the early 2000s, virologists had reached a cautious, alarming conclusion. The Andes strain appears capable of limited human-to-human transmission associated with prolonged close contact. It is the only hantavirus strain in the world for which this has been documented. The MV Hondius departed from Ushuaia, the southern tip of Argentina, Patagonia, the exact geographic heartland of the Andes strain.
Remember the question we started with? Who got off that ship before anyone knew to stop them? We are about to answer that. And the answer is worse than you think. This story has several critical actors, and understanding what each of them knew and when is essential. Oceanwide Expeditions is the operator of the MV Hondius. The company has been running polar and remote expedition voyages since 1991. It is a respected operator in the extreme adventure travel sector. When the outbreak began, the company took the step of confining passengers to cabins and reporting to authorities.
By May 6th, it stated that 2 additional infectious disease specialists from the Netherlands had been dispatched to board the ship and remained with the remaining passengers. 1 medic was already on board. That medic was managing a disease with a 30 to 40% mortality rate alone on an ocean vessel with no immediate hospital access. The World Health Organization, specifically Dr. Maria van Kerkhove, WHO's Director for Epidemic and Pandemic Preparedness and Prevention, became the public face of the response. Van Kerkhove struck a careful tone in her public statements. She confirmed that human-to-human transmission cannot be ruled out. She emphasized that the risk to the general public remains low. But her language is precise and deliberate in the way that WHO language always is when the organization is managing something it does not fully understand yet. The Cape Verde government played a role that deserves attention. When the MV Hondius sought authorization to dock at Praia, the Cape Verdean capital, the government refused. They created an isolation area near the port and coordinated a multidisciplinary team to assist, but the ship was not permitted to come fully ashore. That decision effectively left more than 100 healthy passengers at sea, in contact with a ship where a lethal virus had been circulating for weeks. Spain ultimately agreed to allow the ship to dock in the Canary Islands, Gran Canaria or Tenerife. That decision brought the ship toward European soil, raising questions about containment protocols the moment passengers disembark. The Swiss government entered the story on May 6th with a brief, alarming statement. A man who had traveled on the Hondius had presented at a hospital in Zurich, showing symptoms consistent with hantavirus. He was being treated in isolation. The Swiss government said there was no threat to the wider public. But this patient had already left the ship. He was already home. And the WHO said he had responded to an email from the cruise operator and gone to the hospital on his own initiative. What is actually happening on board that ship right now? Passenger accounts paint a picture that is tense, but not panicked. Travel blogger Kasem Hato, still on the ship as of May 6th, described the atmosphere as very calm. Another passenger, Jake Rosemarin, wrote on Instagram that stricter precautions were in place, but that passengers could still access outside decks and had meals delivered to their cabins. That detail is worth pausing on. Passengers are accessing outside deck areas. On a vessel where a respiratory pathogen, one suspected of human-to-human transmission, has been active for weeks. Martin Anstey, a British expedition guide evacuated from the ship and now hospitalized in the Netherlands, told reporters he was in isolation, undergoing tests, and described himself as doing okay. He added, "I have no idea how long I will be in hospital for." The three who died, a Dutch couple and a German national, have not been publicly identified out of respect for their families. Their deaths occurred across a span of weeks, which suggests the disease moved through the passenger population over an extended period rather than in a sudden cluster. The evacuation process has been methodical but slow. On May 5th, the three most symptomatic individuals still on board were removed by air ambulance from Praia International Airport and transported to hospitals in the Netherlands and Germany. By May 6th, three more suspected cases were evacuated, including two described as having acute symptoms. An undetermined number of passengers remain on the ship as it makes its way toward the Canary Islands. They have been on this vessel for 5 weeks. They have watched fellow passengers die. They have confined themselves to their cabins, and they do not know when they will be home. But here is the part no one is talking about, and it changes everything: the Swiss case. Think about what it means. A passenger disembarked, cleared whatever screening existed, flew home to Zurich, and then developed symptoms. He found out he needed to go to the hospital because a cruise company sent him an email, not a health authority, not a port official, a company email. That is not a containment system. That is a notification system built on the honor code. If you are finding this important, subscribe right now. We are just getting to the most critical part of this story. The international response to the MV Hondius outbreak has been a patchwork of national decisions rather than a coordinated global strategy. And that gap matters. The WHO issued its disease outbreak news bulletin on May 4th, classifying this as a multi-country cluster linked to cruise ship travel. That designation triggers a specific set of international obligations under the international health regulations, a legally binding framework that 196 countries are party to. Countries are required to assess risk, share information, and implement appropriate response measures at points of entry. In practice, what happened was that individual governments made individual calls. Cape Verde refused docking. Spain agreed. South Africa received the British national in critical condition and treated him in intensive care. The Netherlands dispatched infectious disease specialists. Switzerland received a returning passenger with no apparent port of entry screening, having flagged him. The United States has 17 nationals aboard the ship. The State Department has been monitoring the situation. As of the latest reporting, none of the confirmed deaths or critical cases have been identified as American. But with 17 people on board and the disease incubation period for Hantavirus running between 1 and 8 weeks, some of those passengers may still be within the window. Social media response has been significant but generally measured, reflecting a post-COVID public that has become more sophisticated about outbreak risk assessment. The WHO's emphasis that this virus does not spread like influenza or COVID has clearly landed with audiences. Most commentary is expressing concern for the passengers specifically, rather than fear of a broader epidemic. However, experts in pandemic preparedness have been more pointed in their public statements. The combination of factors here, a respiratory pathogen, a confined vessel, the specific Andes strain, potential onward travel by exposed passengers, creates conditions that justify more than routine attention. Here is the detail that mainstream coverage has largely glossed over, and it is the detail that matters most from a public health architecture perspective. The Swiss case reveals a fundamental gap in how we track disease exposure following maritime travel events. When an aircraft lands carrying a passenger who later tests positive for a notifiable disease, aviation protocols, at least in theory, allow authorities to reconstruct the seating manifest, identify close contacts, and initiate tracing. The system is imperfect, but the infrastructure exists. Maritime outbreak tracing is far less standardized. Passengers disembark at different ports, at different times, travel onward through multiple countries. The MV Hondius made stops at some of the world's most remote islands, locations with limited public health infrastructure, before the outbreak was even identified. Now consider the timeline again. The first death occurred on April 11th. The WHO issued its public bulletin on May 4th. That is nearly 4 weeks between the first fatality and international notification. During those 4 weeks, passengers who had been in close contact with the index case and potentially with subsequent human-to-human transmission were continuing to move through the ship, and some were disembarking at stops along the route. The Swiss patient is the visible data point. He is the one we know about because he responded to a company email. The question no authority has directly answered is, how many other former passengers are in the incubation period right now, in how many countries, with no health authority actively monitoring them? This is not a criticism of the WHO or any specific government. It is a structural observation about how our global outbreak detection architecture handles slow-moving maritime outbreaks with extended incubation periods. COVID-19 exposed every crack in that system. The MV Hondius is now exposing one more. The Andes strain has a documented incubation period of up to 8 weeks. The ship left Argentina on April 1st. We are now in the first week of May. Do the math. Some passengers may still be incubating. This story is not over, not even close. Let us be precise about what is actually at risk here and what is not. The WHO has been clear. Hantavirus does not spread through casual contact. You cannot catch it from a cough across a street. You cannot catch it from a surface. The documented human-to-human transmission of the Andes strain requires sustained close contact, the kind that occurs in households, caregiving situations, or the confined shared spaces of a ship. So the immediate risk to the general public, people who have not been on or near this vessel, is genuinely low. The WHO's messaging on this point is accurate, and it is important. But there are 3 distinct risk categories worth understanding clearly. The first is the remaining passengers on the ship. They have been in an enclosed environment with an active Andes strain outbreak for weeks. Whether or not they are currently symptomatic, their exposure risk is real. When they disembark in the Canary Islands, what happens to them? Do they go into monitored quarantine? Do they fly home on commercial aircraft? Do they reunite with families? These decisions will be made by individual governments for their own nationals, with no guaranteed coordination between them. The second risk is the healthcare workers. One medic has been managing this outbreak on board since it began. 2 Dutch infectious disease specialists are now on the ship. Medical personnel who care for hantavirus patients, particularly Andes strain patients, have a documented exposure risk, especially without full airborne precautions. In the 2011 Patagonian outbreak, a physician was among those infected. Healthcare worker safety protocols in a maritime setting are not equivalent to a dedicated infectious disease unit on land. The third risk is the long-tail exposure, the passengers who have already disembarked at earlier ports. South Georgia, Tristan da Cunha, the Azores. Some of these stops were at islands with almost no medical infrastructure. If a passenger disembarked at one of those locations in the first 2 weeks of April, while the first cases were developing on board, and that passenger carried early-stage Andes strain infection, the local population's exposure, and the patient's subsequent travel history would be extraordinarily difficult to reconstruct. The realistic worst case here is not a global pandemic. Hantavirus has never produced one, and the Andes strain's human transmission is limited by biology. The realistic worst case is a cluster of secondary cases in several European countries, discovered weeks from now, with fractured tracing capacity, and 1 or 2 deaths in people who had no idea they were at risk. Infectious disease specialists and public health researchers have been weighing in on the MV Hondius outbreak, and several lines of expert argument have emerged. The first concerns the Andes strain itself. Virologists have been studying its human-to-human transmission capacity since the late 1990s. The scientific consensus, as of 2025, was that such transmission is rare and requires prolonged, intimate exposure. However, some researchers have argued that this conclusion was based on a limited data set, primarily household clusters in rural Patagonia, where social patterns and living conditions differ from a cruise ship environment. A ship is, in many ways, more conducive to sustained close contact than a Patagonian farmhouse. Small dining rooms, shared corridors, shared ventilation systems. The second area of expert comment concerns the WHO's response timeline. Several public health academics have noted that the gap between the first death on April 11th and the international notification on May 4th, nearly 4 weeks, represents a significant detection delay. Post-COVID reforms to the international health regulations, which were debated extensively in 2024 and 2025, were specifically designed to accelerate just this kind of notification. Whether the delay reflects a failure of those reforms in practice or the genuine difficulty of identifying an unusual pathogen in a remote maritime setting is a question the WHO will need to answer. Third, epidemiologists tracking travel-associated disease outbreaks have flagged the expedition cruise sector specifically. These voyages typically visit some of the world's most ecologically intact, rodent-dense environments: Antarctic islands, subantarctic archipelagos, remote South Atlantic territory, and then return passengers to densely connected global transport networks. The MV Hondius is not the first expedition vessel to have a disease event. It is the first to produce a confirmed Andes strain cluster in a maritime setting. Dr. Maria van Kerkhove's framing that this is not a virus that spreads like flu or COVID is epidemiologically accurate, but experts note that it carries its own implicit risk, that policymakers and the public, conditioned to think in terms of airborne pandemic pathogens, may systematically underestimate the specific, targeted danger that a high-mortality, close-contact respiratory virus poses to the people in its direct proximity. We started this video by asking, who got off that ship before anyone knew to stop them? Here is what we now know, and it is exactly as serious as we feared. At least one person did, in Switzerland, found out he was exposed because a company sent him an email. And those are just the cases we know about. Here are 3 scenarios based on current trajectory. Best case, the Canary Islands docking proceeds smoothly, with Spain implementing full isolation and medical screening for all remaining passengers before any onward travel. Returning nationals are placed under WHO-recommended monitoring, at minimum symptom surveillance for 8 weeks post-exposure. The Swiss case remains isolated. No further secondary transmission is confirmed outside the ship, and the outbreak is declared contained by late June. The mortality toll stays at 3. The British man in South African intensive care recovers. The expedition cruise industry updates its protocols. The WHO reviews its maritime outbreak notification procedures. Likely case: the ship docks. Passengers are screened and returned to their home countries under varying national protocols of differing rigor. 2 to 4 additional cases emerge among disembarked passengers over the following 3 to 6 weeks in Europe or North America, each discovered through symptoms rather than active surveillance. Each is managed individually, with no secondary household transmission confirmed. The total case count rises to 12 to 15. 1 or 2 additional deaths occur. The outbreak generates serious reform discussions within WHO maritime health frameworks, but no pandemic-level response. Worst case: active surveillance of disembarked passengers is insufficient. Multiple cases emerge across several countries simultaneously, causing public fear disproportionate to actual transmission risk, but straining health systems' diagnostic and isolation capacity. A healthcare worker is infected in a European hospital. Media coverage creates public pressure for border restrictions that are epidemiologically unnecessary but politically irresistible. The actual outbreak remains containable, but the response becomes chaotic, fractured, and expensive. The Andes strain's documented human transmissibility is revisited by virologists under new data, with unsettling conclusions. The trajectory toward the likely case is already established. The variable, the wild card, is how many disembarked passengers remain unmonitored right now and in how many countries. We want to hear from you directly on this. Here's the first question. The WHO has been emphatic that this is not a COVID-level threat. Do you believe that messaging is reassuring, Or do you think it creates a false sense of security that could slow down the response in the critical early weeks? There is a legitimate argument on both sides. And here is the second question. Expedition cruises routinely take passengers to the most ecologically sensitive, wildlife-rich environments on Earth, places where rodent populations are dense, and contact with the natural environment is the entire point of the voyage. Should the expedition cruise industry face specific, mandatory biosafety screening protocols that standard ocean cruises do not? Or is that government overreach into a niche travel sector that has operated safely for decades? Tell us what you think in the comments. This is a conversation that deserves more than headlines, and your perspective matters. Let us bring this together with three things that matter most. 1. The Andes strain of Hantavirus is the only known strain of this virus capable of human-to-human transmission. Its presence on a vessel departing from its natural geographic range, southern Argentina, and its subsequent spread in an enclosed maritime environment is not a coincidence. It is a preview of the kind of travel-linked outbreak that post-COVID public health frameworks were specifically designed to catch faster. This one slipped through for nearly 4 weeks. 2. The Swiss case is the canary in the coal mine. One returning passenger, identified through a company email rather than active public health surveillance, is now isolated in a Zurich hospital. He is the visible tip. The question of how many more passengers remain in their incubation period, in how many countries, monitored to what degree, is not yet fully answered. 3. The risk to the general public remains low, and that is true. But the risk to specific groups, remaining passengers, their close contacts, healthcare workers managing their care, and the people who live in the communities where they return, is real and requires rigorous, coordinated international action over the next 8 weeks. This story is not over. The ship has not docked. The disembarked passengers have not been fully accounted for. The incubation window is still open. And in the next 72 hours, as the MV Hondius approaches the Canary Islands, the decisions made about screening, monitoring, and quarantine will determine whether this ends here or expands beyond anyone's current projection. Subscribe and hit the bell, because when this story moves, we will be the first to cover it. The passengers on that ship went looking for the edge of the world. They found it. The question now is whether the rest of the world is ready for what they brought back.